Good morning, Marcela. Thank you very, very much for agreeing to join us. And it's wonderful to have you on the webinar. Thank you.
Thanks, Karen. Good to be here. Thanks for inviting me.
A great pleasure. I just want to, at the outset, we would like to ensure that this is for information and education only. It must not be taken as a medical diagnosis or medical protocol. All cases must be referred to a doctor and to a trained physiotherapist. Each patient is different, and so with each patient's treatment. I do know that you work a lot with people within their own homes, so that's always a great benefit, because I think that that's where people really struggle, is in the you know, at home, when they have to care for somebody that they love at home. But just quickly, a quick introduction to you, because you've given us so graciously of your time. You studied physiotherapy and you matriculated at St. Cyprian's, not in that order. And you have work experience with the elderly and those suffering with dementia or living with dementia. Since opening your own practice in 2010, you've increasingly worked with elderly patients in the area, seeing them at your practice and visiting them at their homes, at retirement homes and care facilities too. You like the holistic approach, working with the local GPs, as well as the specialist geriatricians, and more the holistic view of how people with dementia should be treated. So thank you so much for joining us, Marcela. We're looking forward to your presentation. Just to maybe mention, because there were those on our support group that did forward us questions, and that you've been able to build some of the answers to those questions into your presentation, which we really appreciated. Thank you so much for all your efforts. Thank you. Over to you, Marcela.
Thank you, Karen. Thanks for that introduction. And thank you everyone who sent through questions, and I've tried to think through those and research appropriately. Hopefully you'll be able to answer those questions. So the first thing I want to say is that the role of physiotherapy is to really help patients to regain or maintain their mobility. And the purpose of that is we want them to maintain as much independence as possible. So we do that in many different ways. If somebody has had a fracture and they've lost mobility, then we will be looking to help them regain that mobility. But it could also be through helping them to manage pain, to increase or maintain strength, flexibility, and balance, and to assist with safety. And then a part of our role for patients who are no longer able to mobilize independently, part of our role is to assist carers with safe transfers, and also to be able to look after themselves, to transfer in a way that doesn't put the carers at risk, and then with keeping patients comfortable and pain-free. So let's look at what happens as we age. Age-related musculoskeletal changes. Let's bear in mind that posture is the biomechanical alignment of the individual body parts, as well as the orientation of the body to the environment. So what happens as we get older? Firstly, there's a loss of height. We lose approximately 1.2 centimeters every 10 years after the age of 30. So 30 is actually when we reach our maximum height, and then we're gradually losing height after that. After the age of 70, we start to lose height a little bit more quickly. If we think about the spinal column, there are three elements that make up the spinal column: the bones, the vertebrae, the bones, the intervertebral discs between the vertebrae, and the muscles. And what happens with aging is we get a loss of bone size. So we get demineralization of the bones. So even if there isn't osteoporosis, which is a speeding up of the demineralization of the bones, you still get a little bit of a loss of bone size. So the height of the actual vertebra decreases slightly. The second thing is that the discs harden and they lose their flexibility. So the height of the discs becomes decreased and they start to tilt forward, causing an increased kyphosis. So that curve, so we've got normal curves in our spine. You've got your curve at the back of your neck, then the spine comes out a little bit in your middle back and then goes in again in your lower back. So that middle back curve starts to increase. We call that an increased kyphosis. And then we also have age-related muscle loss. I'm going to talk a little bit more about how we lose muscle as we age. But in terms of posture, it's particularly important that we lose muscle in the postural muscles. So loss of muscle mass is called sarcopenia. Between the ages of 50 and 70, muscle strength declines by as much as 30%, especially in the legs. And then over the age of 30, our muscle strength decreases even more quickly. And research shows that there's actually a decrease in both the size of each muscle fiber and the number of muscle fibers. So it is an inevitable decrease, but we can make sure that we don't lose more, that we maintain what we have, and that we don't lose more than we have to by being immobile. So physical inactivity also contributes to a loss of muscle strength, especially in the anti-gravity muscles that are required to maintain a good upright posture. So that further adds to the loss of an upright posture. So, for example, people who, that's part of why a fracture in older age is such a problem, because people who have to be immobilized for a time, so if they're required to lie in bed for a time, that normal muscle loss will be exacerbated through a period of inactivity. Muscle endurance also decreases with age, so that older people tend to fatigue more quickly. And it's these age-related changes in muscles that likely have the greatest consequence for performing your basic activities, such as walking up and down stairs, and getting in and out of a chair. The other thing that happens as we age is that there are changes in the peripheral and the central nervous system. And these are all things that we try and consider when we assess patients. So we always ask about vision. We think about the vestibular system. So the vestibular system is within the ear, and it senses head movement. And if you get changes in the vestibular system, patients often become dizzy, and falls are much more common. And then patients start to lose the ability to feel the contact between their feet and the ground under the feet, and also they lose their joint position sense. There's a decrease in processing speeds within the peripheral and central components of the neural and motor system. So the information that's coming to the feet and back to the head and back again, which is happening very quickly as we're walking, and the surface under our feet is changing, that processing is much slower in older people. So older adults have slower reaction times, slower movement times, slower response times. And they find it much harder to plan and execute actions. So everything is happening more slowly, and they're struggling to, the ability to make a plan to, for example, walk around an obstacle is also slowed down. And then, of course, we have to add to that changes in the cognitive system. So there are always changes in the cognitive system, and we know that not all elderly people suffer from dementia, but 10% of all people older than 65 and 50% of all people older than 80 will have some form of cognitive impairment. Could be very mild, or it could be a dementia. So adverse changes occurring in attention, memory, and intelligence are most likely to affect the older adult's ability to anticipate and adapt to changes occurring in the environment. And this is very important. So how can we help older people to maintain a good posture? We like to encourage weight-bearing exercises for as long as possible. So we obviously want the patient to walk as much as possible. Often with people with dementia, if falls are an issue, then this is best supervised. But we try and encourage people to walk as much as possible during the day. But other things that we can do are marching on the spot, stepping forward, stepping sideways. So it doesn't always have to be walking. It can be within a confined space as well. In terms of posture, the other thing is to choose a firm but comfortable chair that offers a good back support. This is very important. Ideally, the chair should have a fairly high back. It doesn't have to be as high as this one pictured, but it needs to offer quite a lot of support. It's nice for it to have arms. It's not ideal for a patient to be sitting on a couch where they're supported maybe only on one side, because they often tend to collapse towards the unsupported side. So if they're able to sit well back in the chair and be as upright as possible, it will help with posture, especially because older people do tend to spend a lot of time sitting, and particularly those with dementia. One should try not to let the patient slouch in the bed. So we do sometimes see patients sort of half sitting, half lying in the bed. Ideally, if the patient needs to be lying down, then they should be lying a little bit flatter. Otherwise, if they need to sit up in bed, we need to try and get them sitting as upright as possible. If possible, we can let the patient spend a short time lying on their stomachs. It's not always possible. Many older people are not comfortable turning onto their stomachs. And you do have to be careful about the neck and check that the neck is not at a very awkward angle. But as soon as you turn onto your stomach, you're forced to use the muscles down your back, or back extensor muscles, which assist with maintaining an upright posture. So on the next slide, I've just included some very simple postural exercises that can be done in sitting. So the first one is just shoulder shrugging. So lifting the shoulders up to the ears and then relaxing the shoulders away from the ears. So this is very important for the shoulder blades. Many of us tend to sit with hunched shoulders. The shoulder blades get pulled up, so it's as important the lifting of the shoulders up to the ears as relaxing the shoulders, which draws the shoulder blades down the back. The next thing is the diaphragmatic breathing, which is shown in that left corner, this lady sitting on the stool. Obviously, your patient's not going to be sitting on a stool like that. But when we do diaphragmatic breathing, and I've just noticed now that her hand is actually a little bit low, I would think it needs to be slightly higher up over the diaphragm. So either you can get the patient to place their hands over the diaphragm, or you can do it for them. And the idea is that you want to encourage the patient to breathe low down in the lungs. So actually, as they breathe in, the diaphragm relaxes and the tummy comes out. It's also sometimes called belly breathing, because the belly will come out into their hands. As they breathe out, the diaphragm relaxes again and the tummy goes back in again. We're always trying to encourage breathing towards the base of the lungs. You can do neck rotation from side to side. We like to be very gentle with older necks, so don't force into too much rotation, but ask the patient to move within a range that's comfortable for them. Trunk rotations, either with the arms up as shown in this picture, or the arms can be down at the side, but get both arms turning, and you can use, if they're able to, they can use the hands on the sides of the chair to help them get a little bit more rotation. to either side. Very nice exercise. And then arm elevation. And we usually, if they can, we try and do both arms together, because as you lift the arms, you extend that middle portion of the back as well. So while we're talking about exercises more generally, it's very difficult to list all the exercises that one can do, and also it's very patient dependent. But I'm going to just give a few pointers around exercise. So when we're looking at exercises for the elderly, we consider cardiovascular exercise, so getting the heart rate up and breathing up. We consider strength, and we use small weights or those TheraBands. So by small weights, I've actually got a 1/2 kilo weight in my rooms. They're not always easy to find, but sometimes that's all you need. Sometimes when I'm in someone's home, I will find something. Could be a tin or something in the home that one can use as small weights in the patient's hand to increase the weight as they're doing their arm exercises. We do need to be careful not to give too much resistance. The other thing to consider is flexibility. So older people do tend to become very stiff, which often contributes towards pain. And we need to think about flexibility. So the two examples, that I thought of, apart from what we did in the previous slide, which is your flexibility of the trunk and the neck, will be often I will get the patient to lie on their back. I'll bend both knees up, put their feet on the bed, and then we just gently rock the knees from side to side. And you start with a rocking motion, and as they start to loosen up, you can take both knees over to one side, but you keep the shoulders on the bed so that they're getting a stretch through the lower back and through the hip. And then the other thing that often becomes a problem in patients that are becoming less mobile, because they're sitting for such long periods of time, they tend to lose flexibility down the back of the legs. So the hamstrings become very tight, and they sometimes develop what we call fixed flexion contractures at the knees. So it's a good idea with patients that are becoming less mobile to make sure that you can straighten the knee completely and to stretch that regularly. The other component we always look at is balance. So if we're looking to set up an exercise program for elderly people, we will include some balance exercises. So obviously these are going to depend very much on the extent of mobility of the patient. But the one thing with balance exercises to watch out for is that the patient must always be safe. They must always have something to be able to reach out for if they're going to be doing balance exercises. Some of the things to consider are maybe doing 2 short exercise sessions a day rather than trying to exercise for too long. So older people do tend to get fatigued more quickly. So we don't have to fit in all the exercises in one session. It might be beneficial to divide it up a little bit during the day. There was a question about how to see how much exercise is enough. And when I thought about this, I suppose I always try and watch the patient's face to try and pick up any indications of pain. And for me, often the carers are there and assisting, and I will also ask their opinion because they're usually very good at picking up facial expressions and grimaces, which I might even miss. And then we also need to look out for shortness of breath, so be aware of that. One of the exercises that we quite often use for patients that are able to would just be sitting to standing. So it's a very functional exercise because it's something that they need to do all the time. And it's very good for lower limb strength, but it also is a cardiovascular exercise because if you sit down and stand up, several times, you will realize that you're going to start to get a little bit short of breath, and we see this often in these patients as well. So the next thing I'm going to move on to is the question around chest physio. So chest physio amongst the elderly, if a patient has developed a pneumonia and they're coughing, but you're feeling that they're not really managing to clear those secretions. So we always listen, we try and listen to what the cough sounds like. Does it feel like the secretions are just rumbling around in the lungs? Is that cough quite strong, or does it feel like it's so strong and effective, in other words, able to clear secretions? Or is the cough sound very ineffective? When we talk about clearing secretions, it's really nice if the patient can cough secretions up into their mouth and spit them out into a tissue. But it's enough if you can see that the patient coughs up and swallows, that's sufficient. It means that they are clearing secretions out of the lungs and they're then swallowing them, which is fine. The problem is when the patient coughs up, but they're not able to clear the secretions out of the trachea and secretions just go back into the lungs. That's when they're really needing help. If you've been advised to give percussions to the patient, so these are some of the techniques we use to try and mobilize secretions. We will usually do this with the patient in sideline. So I would normally put a towel over the patient's chest. You always use a cupped hand, try not to use a flat hand. A cupped hand is more comfortable. A flat hand is more a sort of slapping action. And it shouldn't cause the patient any pain. And when we do these techniques on babies, they often fall asleep. It's quite a comfortable technique. So just going back a step, we try and encourage, part of the treatment will really be trying to encourage the patient to breathe at the base of their lungs. So that will either be the belly breathing that we were talking about, or if you put your hands on either side of the base of the rib cage. So you can do that in sitting. So especially, for example, if the patient has been given a nebulizer, you want to sit them up so they're nice and upright to give the diaphragm time, space to expand and relax, contract and relax. And then you can put your hand over the diaphragm or over the base of the lungs. And as you do that, you give that sensory input, immediately the patient starts to breathe a little bit more deeply in that area. So that can be really helpful. You want to try and get the air in down into the base of the lungs, and you want to try and get air behind the secretions to mobilize them from the base of the lungs up more proximally, where it's going to be easier for them to cough it out. You can also use this technique in lying, so you get the patient to lie on their side, place your hands over the rib cage, and just encourage some breathing in that area of the lungs. We do try to avoid percussions when the patient is wheezing. So percussions when your hand is cupped and you're clapping over the patient's chest. When a patient is wheezing, it means that their airways are a little bit narrowed, and it could mean that there's bronchospasm. So the little muscles in the airways are in spasm and they're narrowing the airway. So for example, in asthma, you will get that narrowing of the airway, and percussions can increase bronchospasm. So you do need to be careful. I would rather use just a breathing technique in those patients. If the patient's coughing, but you feel like it's really ineffective, you can place their hand, your hand, over the diaphragm. So as the patient coughs, you push onto the diaphragm to try and give a little bit more strength to that cough, to try and help them to clear their secretions. So the next question was around preparations at the home. In the home, this is obviously a very broad question because it depends on how mobile the patient is. But these are the things that I thought about. I just want to talk again about the chair, the patient's chair. We talked about this earlier in terms of posture. So I would say the patient's chair is one of the most important aspects to consider at home. It should be of an adequate height. So it definitely shouldn't be a low chair. And if anything, it would be ideal to try and find a chair that's a little bit higher. You can add another foam cushion, quite a firm foam cushion, to the chair if it's too low, because the height will facilitate standing up and sitting down, and this is something the patient's going to be doing quite often. It should be comfortable, but it should be fairly firm, and ideally have armrests on either side. The other thing to do is to look at the home and to lift any loose rugs. So have a look around. Loose rugs are so easy for elderly patients to catch a foot on, and then they are often unable to react quickly enough to prevent a fall. The other thing that I often feel when I come into people's homes is that we need to declutter, and you'd be surprised how much resistance there is to this. People become very attached to their things, and also for their things to be the way that they've always been. But if you've got to consider that the patient might now need a walking aid and have a walker, those walkers are quite wide, they need quite a lot of space. If we think about patients as they get older, their inability to negotiate around things, around corners, to make plans about how they're going to get around, it's very difficult if there's a coffee table in the middle of the lounge and they're always having to try and navigate around it. It would be better if you could move that out the way and create nice open spaces for the patient to use their walker. And it also means the patient's more likely to use their walker. Often you see a patient will eventually leave their walker behind and start holding onto the backs of furniture because there are too many things in the way. If the patient is still able to shower, you might consider a shower chair, plastic chair with nice rubber stoppers at the bottom, and also a shower mat. I haven't put that down there, but a rubberized shower mat can be really helpful. And then shower rails and or a raised toilet seat. So when I go into someone's home, I would encourage you to think about, just slow down, think about how are you going to get into the shower and where are you going to want to put your hands in the shower. And usually that's where the rails need to go. It's quite a practical, logical process around where the rails should go. And then obviously the raised toilet seat is helpful because the patient doesn't have to sit down as low. And that's the other thing just about the chair, and thinking about getting in and out of the chair just as an exercise, which is very good for muscle strength, is that we should always be encouraging the patients to sit down slowly and to control the down into the chair. So we often see patients falling into a chair, which is very dangerous. The chair could move out of the way, could slip backwards out of the way. But also that is a great opportunity every time they're standing up and sitting down to really use the leg muscles and try and maintain leg strength. So how do we encourage people, elderly people, especially those with dementia, to use assistive devices safely for mobilizing? So unfortunately, it's much harder for elderly people with dementia to use assistive devices safely than their elderly counterparts who aren't suffering from dementia. It's a real problem that we see, and you can have patients that are incredibly frail but not suffering from dementia are able to mobilize themselves safely, whereas patients with dementia who may be not as frail but have got less cognitive ability are more at risk and need to be supervised with mobility. So try and declutter the space, lift loose rugs. There are fewer things for the patient to navigate around. We need to choose the correct device. So if you're going to be using a four-wheeler, So the one that's got, well, there could be a 3-wheeler or a 4-wheeler. So they offer good, quite a lot of support, and they're nice because the patient can get into a normal gait pattern. They can keep going and keep walking forward. They don't have to stop and start. A 3-wheeler would offer a little bit less support. A 4-wheeler would offer a little bit more support, but it is wider. It's a little bit more difficult to negotiate around narrow spaces. If the patient is tending to push the walker too far in front of them, or there's a danger that they're going to go too fast, you might have to use a frame that doesn't have wheels. So they are the ones with the 2 little wheels in front, which do slow the patient down quite a bit, or maybe no wheels. The problem with no wheels is that they have to lift it up in between, and it doesn't help them to produce a sort of flowing gait pattern, but it does slow the patient down. We usually use those ones for a patient who's had a fracture, who really needs to be walking slowly, and then try and move on to something that's got some wheels so that they can get more of a flowing gait. The walker should be of the correct height. So in this picture here, you'll see that the top of the walker should be in line with the patient's wrist. So you stand the patient up, you get them to hang the arm down at their side and check that the top of the walker is in line with the wrist. Not all patients, I do always try that out. So if I feel that the walker is a bit high, the patient might say to me, but I'm comfortable like that, then we'll try both. Then I get them to walk it a bit higher, then I say, let's put it down a bit, try again. So it's not a hard and fast rule. Some patients do find it more comfortable a little bit higher or a little bit lower, but one should always try it out. Get the patient to walk with it, get a feel. How upright are they? Are they able to stand close enough to it? If a patient is maybe weaker in their legs and they're needing to use their arms more, then it's important that the walk is not too high, because they need to be able to push down through the arms to take some of the weight off their legs. And then sometimes patients reach a point, before I say that, with these rollators, there are always brakes on them. And I always try and teach the patient how to put the brakes on and off. So ideally, the patient should go with the walker to the chair, put the brakes on, sit down, stand up, take the brakes off, and take off. But patients with dementia are often not able to get that coordination, or they forget to use them. As the carer, I always try and put the brake on before they sit down, and then as they stand up, the brakes are on, lift the brakes and take off. The 2 other things actually I want to say before we move on from that. One is that I always try and get the patient to use the walker right up to the chair. So often you'll find a patient will come up to the chair, and then as soon as they're close enough to it, they'll let go of the walker, reach out for the chair, and then try and sort of navigate their way into the chair. Ideally, you want them to hold the walker, come up to the chair so that they side onto it, turn around, take a step back. I always ask the patient, can you feel the chair behind you? When you can feel it, reach out with one hand, and now you can sit down. And the other thing is, when they're standing up, try and cue the patient not to put their hands on the walker and pull themselves up. They might want to put one hand on the walker, but the other hand should be on the arm of the chair, so that they are pushing more than they're pulling. Otherwise, they're going to pull the walker over towards them. Getting up off the floor, there was a question about dizziness. So symptoms of dizziness should always be seen to by a doctor, because there are lots of reasons for it that can be managed. But I do appreciate that it's not always possible to identify and treat the cause. I do have some patients who have ongoing dizziness that hasn't been, it can't be managed medically. It can be helpful sometimes with those patients. So maybe they've got postural hypertension. So as they're standing up, their blood pressure is changing, and their body's ability to adapt to that is quite slow. If that's the case, you can ask the patient to just walk, just move their feet up and down on the floor before they stand up. So that can be helpful. And then the other thing is that to remind the patient to stand for a moment before they get going. So they'll often stand up and start walking, and that's when they're very at risk of falling. So there's lots of verbal cueing. They're verbal cues that carers can give to try and help patients to manage if it's not something that they're able to remember for themselves. If a patient lands on the floor, stay calm. Look for injuries. So we're looking for, the patient might complain of pain, but you're looking for a limb that's at an awkward angle, or for swelling or redness or bruising that's starting to appear. If you think there might be something there, if you sort of palpate tenderly or gently around that area, the patient might respond. You might be able to see that it's sore, or maybe it's not. And what you do is you set a chair next to their feet and another one at the head. Then you roll the patient onto their side. So it's generally easier to get the patient onto their side first, and then from that position, see if you can get them into a kneeling position, which is, so to pull a patient up who's lying on their backs to try and get them to sit up and stand is very, very difficult. If you can get them to roll onto their side, bend their knees up, and then they keep rolling over towards the tummy, they can often come up onto their knees. Once they're in that position, they put their hands on the chair in front of them. Now they're in an upright kneeling position, and then you can put the chair behind them and help them from that kneeling position to sit on the chair. It's good to practice this with somebody else, not an older person first, so that you, because there's always a certain amount of panic associated with having an older person on the floor, and what's happened, and are they injured, and how are you going to get them up. So it's quite a good idea to practice this with a younger person to help someone get up off the floor and to work out how it would be best to manage this. Sleeping positions, we generally don't like too many pillows, although some patients get short of breath and they like to have more pillows. If they're lying on their back, usually 1 to 2 pillows. If the patients are lying on their side, the pillow should fill the space between the head and the tip of the shoulder. So if the bed is on this side and the pillow is too flat, the patient's lying with their head down towards the floor all night, the neck becomes stiff. If there's too much pillow, the head is up towards the ceiling, and also could become stiff. If they're inside lying, it's comfortable to have a pillow between the knees. And then there's a question of, should there be, if they're lying on their back, should there be a pillow under the knees or not? So if a patient is specifically suffering from back pain, it can be very comfortable to have a pillow under the knees instead of them lying with their knees extended. However, I have mentioned that these patients are at risk of developing knee flexion contractures because they sit for such long periods. So it shouldn't really be the norm if the patient's lying on the back to have a pillow under the knees. Aches and pains. Exercise and posture in the chair and the bed can help a lot with preventing aches and pains. So keeping the patient moving and keeping them in good postures can be very helpful. I found patients often enjoy heat in the form of the happy hugger or hot water bottle on an area that seems tight or painful, but be very careful with the temperature. We don't want to burn the patient. And then I think the question of when is an ache or pain serious is really around when have things changed. So if the patient was able to walk quite comfortably and now they're not, something's changed, and that probably needs to be seen to. So whatever level the patient's at, if that changes, then that's something that I would want to look at. We're looking for swelling, for redness, or increased temperature in joints or muscles. and also for changes in a range of movement. So they could bend the leg up and now they can't, or the ability to weight bear. So they were able to stand comfortably, now they're not standing on that leg, especially after a fall, because it is possible to miss injuries after falls. Thank you, Karen. I've come to the end of my presentation. You might have things that came up in your mind while I was talking.
Well, you know, I'm just struck by the amount of information and how rich and how deep the content is. You really answered all the questions and more that came through from our support group members. So, Marcela, thank you very, very, very much. You spent a lot of time covering all the aspects and also covering them in a very, very practical kind of manner. And I think that's always important. You know, we do try and encourage people to keep their loved ones at home for as long as they possibly can. And I think, you know, COVID has also, you know, place the extra burden on, you know, what should I be doing? Should I be doing chair exercises? What do I do if, you know, mom has a dizzy spell and she falls? So all of these kinds of questions, I think, really arose from practical challenges that people had in their homes, but you've been able to answer them for us. And we're enormously grateful for that. I think we do also want to just put the word of caution again, that if anything does change in their loved ones, that they need to go and see either their GP, or if they have already been at a physio, to go back to the physio for the necessary checking out, because I think that at the end of the day, we're really just lay people who are trying to empower. But I think your knowledge and your skill in terms of what actually is appropriate for that particular problem is very, very important. So, you know, don't, we're just saying to people out there, please don't dismiss the fact that you can do this all at home and by yourself. You know, physiotherapists and those allied health professionals are there for a very, very specific reason. And it's important that if there is additional work that is needed or additional care, that we get the professional care that is needed from yourselves, or an OT or a speech therapist, etc., etc. So just thank you very, very, very much, you know, to you for your wonderful presentation, very well researched and very well succinctly put together. If there are any questions that people have, they can send the questions to us at info@dementiasa.org. And then we can forward them on to you, I'm sure. There won't be zillions, but I, you know, if there's one or two that are required for answering.
Karen, I'd be happy to do that. And hopefully there are some helpful tips. I've met some incredible carers in my time being in people's homes, and I really have a lot of respect for the work that they're doing.
Absolutely. And, you know, they really always are under, they're always so well-intentioned and under very, very, very difficult conditions sometimes. So